Welcome everyone. Good morning or good afternoon, depending on where you are in the world. It's a pleasure to welcome you today to this webinar hosted by the Lung Cancer Policy Network, focused on building the economic case for lung cancer screening. Just before we get started, a couple of housekeeping points. Firstly, to notify you that the webinar is being recorded. Secondly, that we would love to hear your questions, so please use the Q&A box which is located on the bottom of your screen. And finally, the webinar will be taking place in English, but closed captions are available using the toolbar at the bottom of your screen, and also you can enable translations via Zoom if you wish to as well. So firstly, I'll briefly introduce myself. My name is Helena. I'm the programme lead for the Lung Cancer Policy Network Secretariat team based at the Health Policy Partnership in the UK. I'll take a few moments before introducing our panellists to briefly introduce the Lung Cancer Policy Network and why we've brought this webinar together today. So the Lung Cancer Policy Network is a global multidisciplinary alliance of just over 110 members from around the world, including patient advocates, researchers, clinicians, and industry representatives, all with the goal of elevating lung cancer as a policy priority. As a network, we have long advocated for the implementation and policy commitment for lung cancer screening. Why have we done this? Because lung cancer is one of the leading causes of cancer-related deaths. On the next slide, you'll see some statistics on the economic case for lung cancer screening. By screening for lung cancer using low-dose computed tomography for those at highest risk of the disease, we can detect more cases of lung cancer earlier, where people have more opportunities for a wider range of treatments, including potentially curative surgery, and therefore also reducing the costs of treatment when it does take place at a later stage of the disease. Lung cancer is also, the cost of lung cancer treatment to the global economy are also predicted to rise, making the case for lung cancer screening implementation around the world all the more urgent. As a network, we have produced several tools and resources to support those working on lung cancer screening to ensure that more people around the world have access to this critical tool. As a network, in 2023, so almost 2 years ago, we launched a framework to support the implementation of lung cancer screening. This framework takes a health systems approach and is a flexible and very practical tool that covers the key elements across the health system that are needed to design, plan for, and implement a successful lung cancer screening programme according to the needs of the health system and the risk profile of lung cancer in different countries. The framework covers 6 key topics of the health system, including governance, workforce and technical capacity, financial planning, eligibility and recruitment, screening protocols and delivery, and also data monitoring and evaluation. The framework is designed to be a very practical tool, so whilst the actual framework itself takes you through a series of questions to help understand what a lung cancer screening programme would look like in your health system, it's also accompanied by many freely available tools and resources on our website to help with planning. We've also just launched an additional series of resources and case studies specifically focused on financial planning for screening, which I'll go into a little more detail. So why use the framework and why did we develop this tool? So it is our hope, and from feedback that we've had on use of the framework so far, it's great to see that the framework is being used to help countries where screening isn't already available understand how ready they are for implementing and developing a screening programme. It can be used where screening isn't currently in place to generate a detailed plan for what a screening programme should look like in accordance with the specific needs of different health systems. Where locations are aiming to get policy commitment for a screening programme for lung cancer, using the implementation framework can also support with policy engagement by helping put together the plan. And it also helps understand where there may be gaps that need to be filled across the health system to help inform planning and decision making. So one of the things that we have recently launched and why we've brought together this webinar today is recognising that many people working in lung cancer screening, particularly the early stages, such as developing pilot programmes or clinical studies, that developing the financial case and policy commitment requires creating the economic case for screening implementation and a screening programme. With this in mind, the Lung Cancer Policy Network has recently launched a series of additional resources that are specifically focused on financial planning for screening programmes. This includes case studies on how programmes in Australia and also England built the economic case for screening in those settings ahead of implementation and rollout of screening programmes. And we're very pleased that Professor Baldwin from the UK will be speaking today, and also provides reference resources to help understand the different types of economic models that can be used for screening programmes to help generate economic evidence to inform future implementation. And I'm very pleased to welcome our first speaker, who will go into much more detail about generating the health economic case for lung cancer screening, including some case studies from his work in Sweden. And that is Dr. Thomas Hofmarcher, who's with IHE, the Swedish Institute of Health Economics. Thomas, thank you so much for joining us, and over to you to share the principles of health economics analysis with us.
Thank you, Helena. Hello, everyone. Thank you for the opportunity to be part of this seminar. My name is Thomas Hofmarcher. I'm a health economist and research director at the Swedish Institute for Health Economics, and I'll be talking about the health economic case for lung cancer screening. Today, Swedish Institute for Health Economics is more than 45 years old. We were part of the Swedish government for most of our history, but since 2010, we are an independent private research institute that works together with all stakeholders in the healthcare sector, both nationally and internationally. Next slide, please. I have no conflicts of interest to report. Next slide, please. So let's look at some key statistics to give you some intuition why lung cancer screening might make sense. So if we start from the left, you see that the stage of diagnosis in England, and the picture you see is that more than half, 54% of newly detected cases of lung cancer are in stage 4 in metastatic disease, whereas only 17% of cases are detected early in stage 1. And that has implications for survival, because we know that in stage 1, patients have a 57% chance to survive for 5 years, whereas in stage 4, they only have a 3% chance to survive for 5 years. And also, the treatment costs differ by the stage of diagnosis. So patients diagnosed early in stage 1 cost around 11,000 euros to treat in Belgium, whereas patients diagnosed in stage 4 cost 8 times as much to treat, around 88,000 euros. So based on that observation, it seems that lung cancer screening could in fact lead to the detection of more cases in earlier stages, and thereby both improve the survival chances of patients and reduce the treatment costs to the healthcare system. So it's actually could be a win-win situation here. Next slide, please. And there's already the clinical evidence for lung cancer screening with low-dose CT is well established. There are the two largest randomized controlled trials are the National Lung Screening Trial in the US and the Nelson trial in the Netherlands and Belgium, which both showed similar reductions in mortality. So the evidence that low-dose CT screening works is well established. Next slide, please. But then the question is, even if the clinical evidence is there, what about the cost implications of screening? And the first question to ask is probably, well, how much does a screening cost? And a low-dose CT scan costs around 100 to 300 US dollars in high-income countries. And for that money, you could ask yourselves, well, how many, or if a patient is diagnosed early in stage 1, thanks to screening, compared to being diagnosed late in stage 4, well, how many low-dose CT screens could you actually do for 200 euros for the safe costs of one patient? And the answer is 385 people could be screened to not incur any economic loss for the healthcare payer Whereas in addition, you might also have saved the life of that one patient that you detected early instead of detecting him or her late. Next slide, please. And so you probably understand a little bit that when you look at lung cancer screening from the point of view of a health economist, you're thinking about this balance between health outcomes and costs. And we typically call this cost effectiveness. This is what we want to establish for any new kind of intervention, such as a lung cancer screening program, before we implement it in our healthcare systems. Next slide, please. So in Sweden, our institute has actually conducted 2 reports on the cost effectiveness of lung cancer screening. Both of those studies were conducted before we implemented a pilot program on lung cancer screening in the healthcare region of Stockholm back in September 2022. And I'll be giving you some details about these two studies in the next few slides. So in the first study, we only looked at the screening program for women in region Stockholm. Why women? Well, women already go to mammography screening. So the idea was to invite those women at the time when they are doing the mammography also to do low-dose CT scans in case they are eligible, because the focus is only on women who are current or former smokers. In the second study, we had a national scope. So it was a national screening program for men and women that we evaluated. And again, the focus was here on people with who are current smokers or who have a history of smoking, although the criteria differed a little bit. Next slide, please. When it comes to the organization of these 2 studies that we conducted, so you see the region Stockholm program to the left and the national program to the right. And when you do these evaluations, you have to think about, so how many patients or how many women or men will actually participate. And these assumptions are really crucial because they will inform in the end how many people you're supposed to screen and how many people will potentially benefit from earlier detection. And you see that on the right-hand side, in the national program for Sweden, we assumed that when we reach out to the target population, we assume that 50% respond to a survey where we try to elicit their smoking behavior, is responding to the survey. The reality of the pilot program that was conducted in Stockholm was that only 33% actually answered that survey, whereas the people that got an invitation based on the survey answers, we anticipated that 70% would participate, but the reality was that 90% of those that were invited actually participated. So you see that you have to do assumptions, but the reality might differ. So once you implement a screening program, it would be good after the first or the second year to do a re-evaluation of the actual statistics that you can already see. Next slide, please. So the final results of both costing studies are shown on this slide. And here you see, to begin with, in the table, costs, because introducing a screening program will cost money. There are fixed costs in terms of administration and IT. There are variable costs for screening in terms of also administration, the low-dose CT scans, re-examinations, additional diagnostics, and so on. All of these will create additional costs. Another thing that will create additional costs are the treatment costs of early-stage patients, because we will detect more patients now in early stages. So their total costs will increase, whereas the treatment costs for patients diagnosed late in stage 4, that will decrease because there will be fewer patients diagnosed with stage 4. And then if you add up all of these numbers that you see here, then you see that according to our calculations, the net costs are still positive. So we would still need to invest more into screening, so additional money, despite the savings of lower treatment costs for metastatic patients. But when you look at the health outcomes, the number of deaths would be reduced. There's a minus sign in front of those numbers. The health outcomes in terms of the quality adjusted life years quality increases. There's a plus sign in front of the numbers. So putting the costs and the health outcomes together, we receive an incremental cost effectiveness ratio, an ICER, of 170,000 Swedish crowns per QALY in first example, and only 17,000 Swedish crowns per QALY in the second example. And we can also compare this to the cost effectiveness ratio of other existing screening programs in Sweden, like colorectal cancer screening, which has an ICER of 9,000. Cervical cancer screening has an ICER of 27,000. So the lung cancer screening program, if we would do it like on a national basis, is somewhere in the middle between colorectal cancer screening and cervical cancer screening. Whereas mammography screening for a younger age group of women between 40 and 49 years is actually has a higher cost effectiveness ratio, meaning it's not as cost effective as, for instance, a lung cancer screening. Next slide, please. So given this result of the modeling studies, the question is then, how valid are the numbers? Because any modeling studies, by definition, has a lot of uncertainties, and there are many potential determinants that will affect the cost effectiveness of. So in terms of the determinants of cost effectiveness, the target age group plays a role. The broader the age group, the less cost effective a program will be, because especially if you target younger patients or younger age groups, because there will be fewer patients in those younger age groups. The targetable group is also important. Are you only focusing on inviting current smokers for screening, or also former smokers, and how heavy smokers have they been? All of that will have implications on the detection rate. The screening interval also matters for the costs. Are you doing it annually or biannually? The participation rate, I've already talked about that. The treatment costs by stage is also an important determinant, and that might change over time as well as we get new treatments introduced at various stages of the disease. The type of costs that we include in our considerations also matters. Are we only applying a strict healthcare perspective, as we have done in Sweden, or are we looking at a broader impact and also looking at a societal perspective, and including, for instance, productivity losses of patients that die prematurely before retirement age? Are we considering costs of smoking cessation services that are integrated as part of a lung cancer screening program? And there might also be leaps in the screening technology, such as AI-powered digital pathology, which might affect the cost picture, and therefore also affect the cost effectiveness and essentially the health economic case for lung cancer screening. Liquid biopsy is another major determinant which might become a reality in the coming years and then affect the cost effectiveness. Next slide, please. So my final slide is about experiences from another country, from the US, on the cost of lung cancer screening so far, because lung cancer screening has been recommended in the US for more than a decade now. And the reality is that lung cancer screening the total cost of it is much cheaper than other screenings, and only accounts for 1.5% of all screening costs in the US in 2021. And even if the participation rate in the US would be higher, than lung cancer screening would still only constitute a comparatively small cost share of all screenings. So the other screenings being breast cancer, cervical cancer screening, prostate cancer screening, and colorectal cancer screening here in the US. So with that, I hope I've given you a small taste of the health economic aspects of lung cancer screening. Thank you very much.
Thank you very much, Dr. Hofmarcher, and thank you for your patience. Sorry to interrupt your presentation with the sound. I think we got there in the end. Wonderful. And I can see some questions coming in from the audience, and we will be moving on to a panel discussion once we've heard from each of our panelists. So I hope that it sounds okay to hold your questions for a short while, and we will get to them. And also just to highlight that any questions that we may not quite have time to get to during the panel discussion, we will make sure to answer for you on our website, working with each of our expert speakers today. So thank you very much again, Dr. Hofmarcher. And now I'm very pleased to introduce you Professor Thomas Stargardt with the University of Hamburg, who is here to speak about the Strengthening Screening for Lung Cancer in Europe project, otherwise known as SOLIS, on adapting economic models for health systems across Europe. Professor Stargardt was unable to join us live in person, but he has very kindly pre-prepared his presentation for us. And if you do have any questions for Professor Stargardt, he has also very kindly offered to be put in touch with any participants over email. So we will ensure to get any questions to him directly and also answer them on our website afterwards. So we'll go ahead and share Professor Stargardt's presentation now.
Yeah, all right. Thank you, Helena. So it's now my pleasure to tell you a bit what SOLIS is doing to provide evidence on cost effectiveness for health systems in Europe. So as part of our activities there, we've reviewed existing models. We then developed a health economic model of our own based on previous work. And the idea of a model is to simulate that people within a given eligible population develop lung cancer over time. Then also to simulate how the screening will increase or alter the chances of detecting lung cancers, in particular in earlier stages. And then also simulate what's happening after lung cancer is detected, so how lung cancer is currently treated. So in a nutshell, the idea of a model is to simulate the gain in life years and the gain in quality of life, comparing a situation with and without a screening program. Let me show you the model. This is the idea is kind of that it abstracts from reality, so it is a simplification, but the core use is that it still tries to get the essentials from the treatment process and from the process of the disease. So what you see here now is a so-called Markov model. These little circles, they represent health states. And you see here on the left-hand side, the so-called natural history model. So that's actually the model simulating the cohort that's eligible for the screening, how they develop lung cancer over time. So you see the health state and you see the errors, and the errors indicate that people can move between these health states. So some people will develop lung cancer over time, and that lung cancer will then progress over time. The second part of the model tries to simulate the detection probabilities. There's two ways that lung cancer can be detected in our model, and one is, of course, through screening, and the other is through kind of symptom presentation and a standard clinical examination. So if there's no screening, you go there because you feel unwell. And of course, the detection probabilities, in particular in the earlier stages, are much higher if there is a screening program compared to just the symptom presentation and standard clinical examination. Once patients are detected, they enter the treatment part of the model, and that's the place where we simulate how treatment is going. So people may receive surgery, or surgery plus chemo, or plus radio, or even plus immunotherapy and target therapy, or they may start with chemo, or they start with target therapy and immunotherapy. So all possible combinations are kind of in the model. Of course, being detected in stage 1 gives you a very high chance of getting surgery, whereas being detected in stage 4 gives you rather a chance for getting chemo plus radio or even palliative care right away. So this kind of the idea that if the screening kind of allows a higher detection, in particular in the earlier stages, results in people being stage shifted in the treatment and the model as well. After treatment, there are so-called aftercare states, which patients then are shifted to, and then they also allow a so-called relapse, of course, with the relapse probability depending on the stage of the cancer that the patients had before. And of course, the model also takes into account that people may die from lung cancer, but also from other natural causes throughout the running of the model. So this is kind of the basic model, and in the model, each of these health states, it's not only that we have the epidemiology of going through them, but also that we that each health state also costs are incurred. So the surgery has a certain cost, the chemotherapy has a certain cost, the target therapy has a certain cost. So this is counted, as well as the time that patients are alive, and also the quality of life that the patients spend that time. So in the end, this model kind of simulates for the same cohort a situation with lung cancer screening and a situation without lung cancer screening, and it calculates the life years gained and the quality of life and the cost, and this incremental cost effectiveness ratio, which is kind of the cost per life year gained, which means this is kind of an indicator of the price we pay for doing screening instead of having no screening. For the model to do that, we have a lot of data that enters in there. We use a lot of epidemiologic data on lung cancer progression and mortality, which is coming from local registries and SOLACE pilots in the literature. We have data on the treatment distribution. So, what's the likelihood of getting surgery if you are a stage 1 lung cancer patient, or if you're a stage 2 cancer patient, with cost data for treatment and also for the screening itself and the diagnostic workup. That's coming from local reimbursement tariffs or even sick fund data for some countries. And we calculate, we also have data in there on the quality of life for each of these health states coming from the literature. And then we also calculate regained productivity in terms of patients who have been successfully treated eventually, or to some extent returning to work. We also take this into account. Within the SOLACE, we do this cost effectiveness analysis for Croatia and Estonia. This is where we have first results already. This is something I would be happy to show in about half a year or 3/4 of a year. And we're also working on getting the data in for Ireland and for Poland, which will probably yield results for cost effectiveness at the end of SOLACE. So with that, I hope to have given you some outlook about what SOLACE is doing on cost effectiveness, and that we will provide some information on cost effectiveness, in particular for countries which at the moment, where there's at the moment not that much evidence available. Thank you very much.
Wonderful. And thank you again to Professor Stargardt for sharing his presentation ahead of the webinar today. Our next speaker is Renata Chloupková, who is going to share her experiences from the National Screening Centre, which is part of the Institute of Health Information and Statistics in the Czech Republic, on building the economic case for screening in the country. Renata, thank you so much for joining us, and over to you for your presentation.
Good afternoon, everyone. Thank you very much for the invitation. My name is Renata Chloupková, and I represent the National Screening Center of the Czech Republic. Today, I will be presenting on how we have built the economic case for lung cancer screening in our country. Next slide, please. Lung cancer remains the leading cause of cancer deaths in the Czech Republic for both men and women. This chart is based on national registry data, and this chart highlights the consistent and significant burden of lung cancer mortality over recent years. Lung cancer accounts for 4.2% of all deaths in the Czech population. Next, please. Here we see the time trends in incidence and mortality for lung cancer over time. The mortality rate is quite similar to the incidence rate in the long term. Around 6,500 patients are newly diagnosed with this cancer each year, and approximately 5,200 patients die from it. A very high proportion, more than 65%, you can see it on the right side of the slide, of new lung cancer patients in the Czech Republic are still diagnosed at clinical stage 3 or 4. highlighting the need of earlier detection through screening. Next slide, please. This slide sums up key tasks for the National Screening Center. The National Screening Center plays a central role in supporting the preparation and rollout of screening programs. This includes assessment of technologies, defining screening strategies, and setting up implementation and monitoring frameworks. Next, please. We developed an evidence brief based on health technology assessment principles. This included multi-stakeholder input, modeling potential benefits and harms, estimating the cost of illness, and designing a feasible population pilot program. Also, the program steering committee was established, and all the preparatory work started in 2019. Next slide, please. All results were modeled for a 5-year pilot program. For modeling, we used the data sources from the Czech National Health Information System. We have patient-level data from the Czech National Cancer Registry and reimbursed healthcare. We also used Nelson study results and European Health Interview Survey national data. Our lung cancer screening pilot is designed as a 3-step process. The first is a visit to a general practitioner, then an examination by a pneumologist, and a low-dose CT examination performed by a radiologist. Within the 5-year pilot, each participant should complete this process 3 times. And the target population consists of men and women from 55 to 74 years. They are current or ex-smokers with heavy smoking history. Next slide, please. Model calculation of the effectiveness of the program was based on simulated results of 1,000 persons who participated in all 3 rounds of program. After 3 rounds of screening, 3,251 low-dose CT scans are expected to be performed. This number includes also repeat scans. And we expect a total of 67 positive radiology results. These results indicate a referral for further multidisciplinary assessment at a pneumology or oncology center. More than half of the positive low-dose CT results, 35 out of 67 were false positives, and it is estimated that 32 lung cancers can be detected through screening, of which 19 are estimated to be operable, 5 that would have been detected without screening, and 8 were inoperable. We also estimate around 10% of screen-detected cases around 10% of screen-detected cases could represent overdiagnosis. These overdiagnosis cases, they are 3 out of the 19 operable cancers. And given the available data on the epidemiology of lung cancer in the target population, 34 cancers can be expected over 6 years in the absence of screening. In comparison to the cancers detected through screening, after accounting for overdiagnosis, we observe 5 interval cancers. And we consider a 2-year follow-up after the last round of screening. Next slide, please. And based on the previous calculation and estimate of the years of life saved, including cost per 1 year saved, was made. As usual, we compared a model without screening against a model with screening. Estimation of stages was made thanks to the National Cancer Registry in the model without screening, and for model with screening we used the Nelson study data. Based on our model, lung cancer screening appears to be cost effective. And thanks to the early detection program, approximately 102 years of life are saved at a cost of 5,900 euros per 1 life year saved. So to sum it up, next slide, please. Yeah, our modeling and preparation supported the launch of the Czech national pilot in 2022. The program is governed by the Ministry of Health and administrated by the National Screening Center, ensuring alignment with international guidelines and local needs. The cost-benefit modeling will be validated using real-world data that is already being collected as a part of the ongoing program. And that's all for me. Thank you very much for your attention. And I would like to acknowledge all our partners and stakeholders who contributed to this work. And please free to contact me with any questions or follow-up. Yeah, thank you.
Thank you very much, Renata. And I think it's particularly insightful to see the progression of the modelling that you conducted through to what's coming through from the real world impacts that you're starting to see from the programme and how you're planning to take that forwards as well.
Thank you.
Thank you. Our fourth speaker, I'm very pleased to introduce is Professor Pan-Chyr with National Taiwan University, who is also one of our members of the Lung Cancer Policy Network. Before I invite Professor Yang to begin, just a brief reminder that you are very welcome to share your questions in the Q&A, and I can see several coming through already, so we look forward to getting to those in our panel discussion. But for now, Professor Yang, over to you, and thank you very much again for joining us.
Thank you, Helena. It's my great pleasure to share with you how we build the economic case for screening in Taiwan. Next slide. So this is the content of today's presentation. Actually, Asia has the highest disease burden of lung cancer in the world. Non-smoking lung cancer is a different disease and prevalent in Asia. And economic and health burden of lung cancer in Taiwan. And then I will talk about the feasibility of screening for non-smoking lung cancer. And then I will show you the stage shift and mortality reduction and also the cost-effectiveness study based on the lung cancer screening in Taiwan. Next slide, please. We all know that smoking-related lung cancer is the #1 cause of cancer mortality, but you look at the non-smoking lung cancer, actually ranked 5th in the global cancer deaths. And then you can estimate that more than 30% of lung cancer patients, actually, they did not have smoking history worldwide. Next slide. Asia has the highest disease burden of lung cancer in the world. You can see about 63% of lung cancer occur in Asia, and 63% of lung cancer mortality occur in Asia. You want to have a global better lung cancer control, Asia is the place that we should focus on, especially in East Asia. Next slide, please. You look at the smoking prevalence of lung cancer patients by gender in Asia and Western region. You can see mostly lung cancer in United States and Europe. Men and women, they have smoking history, but in Asia, especially Eastern Asia, most of the women lung cancer patients, they did not have smoking history. The smoking prevalence in Eastern Asian in women is very low. You can see here in Taiwan it's only about 5.9%, and in China 5.2%. It's very low in women. Yet lung cancer is the leading cause of cancer mortality in many countries in East Asia, including Hong Kong, Korea, China, and Taiwan. Next slide, please. Actually, lung cancer is the most serious health burden in Taiwan. It's the #1 cause of cancer mortality both in men and in women. And our health insurance spends most of our resources taking care of lung cancer patients. But the lung cancer mortality is still very high, and because half of the lung cancer patients actually diagnosed in late stage. Next slide, please. This is the fact. Actually, 2/3 of our lung cancer patients, they did not have smoking history. Only 1/3 of them, they had smoking history, especially in women. 94% of them, the lung cancer patient women, they did not have smoking history. And lung cancer is the leading cause of cancer mortality, most in men and women. And the smoking contribution is very low, both in men and women. And you can see in stage distribution, more than half of the patients actually diagnosed in stage 4 disease. Next slide, please. So what are the risk factors for non-smoking lung cancer? Actually, we identify some endogenous risk factors. Most importantly is the family history. Some germlines such genetic accessibility and a female gender in East Asia, they are high risk. Exogenous risk, the most important one would be the air pollution. Next slide, please. So we found that family history is a very important risk factors. Actually, in this prospective study, we follow 1,102 participants. They have family history of lung cancer. We follow for 10 years. You can see here the cumulative lung cancer detection rate is up to 4.5%, especially those with multiplex family, they increase the risk up to 7.7% after 10 years. Next slide, please. And some SNPs associated with the non-smoking lung cancer, totally there are around 25 of them have been identified, which may be helpful to develop a polygenic risk score to identify the high-risk population. They can benefit from low-dose CT screening. Next slide, please. So we conduct a talent study because we are more than 2/3 of our lung cancer patients, they did not have smoking history. So in this talent study, we focus on non-smokers. Age 55 to 75 years old, they have one of the risk factors, including family history, passive smoking history, chronic lung disease, high cooking exposure, cooking index high, or cooking without using ventilation. Totally, 12,011 are enrolled. Half of them have family history of lung cancer. Next slide, please. And actually, in this talent study, we found that the lung cancer detection rate is up to 2.6%, higher than Nelson and NLST. If we only include the invasive lung cancer, it's 2.1%, still very high, and 96.5% of stage 0 to 1, 77.4% of stage 1. That means that 96.5% of them are potentially curable by surgery. And we found that family history may increase the risk of lung cancer. Next slide, please. So we convinced our government to start the nationwide low-dose CT screening since July 2022. So far, we have screened more than 200,000. This is a 2 years result. This particular study, we aim to double the stage 1 disease and 5-year survival by 2030s. It is a biannual low-dose CT screening program focused on 2 populations, smokers, 30 pack years, from 50 to 74 years old. And after 2024, we roll down to 20 pack years. And another group would be lung cancer family history, especially non-smokers or light smokers. In female, we start from 45 to 74 years old. You can see here the overall lung cancer detection rate is up to 1.3%, and 74.4% of them are stage 1 disease. And in heavy smoker, the detection rate is only around 0.8%, and 60% are stage 1 disease. In those with family history of lung cancer, you can see in non-smokers, the detection rate is up to 1.8%, and nearly 90% of them are stage 0 to 1. And if you just consider stage 1 disease, is more than 80% of them, they are stage 1 disease. Next slide, please. So this is the stage shift. Before screening, you can see here 50% are stage 4 disease and 30% are stage 1 disease. By low-dose CT screening, you can see we increase the stage 1 disease from 30% to 74%, and stage 4 disease decreased from 50% to 7%. So we can estimate that we can reduce the lung cancer mortality by 53% through the stage shifting. Next slide, please. So we use AI to generate a virtual control group through using our lung cancer National Lung Cancer Registry. You can see here we can reduce the 36% mortality in smoker by 10 years, and in those with family history of lung cancer, mainly non-smokers, we can reduce 67% of lung cancer mortality. Next slide, please. We also did the cost effectiveness study by machine learning. We used 2 GDP. You can see using the talent study, it is cost effective. As you can see here, a low-dose CT in Taiwan costs around $140, and a third generation tyrosine kinase inhibitor, which we use for the stage 4 disease, EGFR mutant tumor, is equal to low-dose CT. So the government was convinced that it is really cost effective. So next slide, please. So I conclude here, non-smoking lung cancer is a new emerging health threat, and there are some genetic susceptibility, and air pollution may play a very important role. Lung cancer screening for non-smokers may need a different strategy, and non-smoking subject with risk factor should be screened. Our national lung cancer screening show that it is cost effective and can reduce lung cancer mortality. Thanks for your attention.
Thank you very much again, Professor Yang, and we're looking forward to coming back to your points on making sure that eligibility is appropriately tailored to the national context in the panel discussion. And our final presentation for today will be from Professor David Baldwin, based in the UK at the University of Nottingham, focusing on the progression of the health economic evaluation for the UK National Lung Cancer Screening Programme. David, thank you again for joining, and over to you.
My name is David Baldwin, a consultant respiratory physician from Nottingham. I'm delighted to be able to present this review of the health economic evaluation for the UK National Lung Cancer Screening Programme. This took place between 2020 and 2022 and represents a lot of work by a lot of individuals. I have the following disclosures that shouldn't impact on the content of the presentation. I'm going to start by explaining the role of health economics evaluation of screening in the UK. I'm going to give you a very basic description of the model that was used, and then talk about how we revise the evaluation through clinical input and better provision of data, and finally look at the results and see how much they changed from the initial evaluations. The UK implementation of lung cancer screening has not been through the standard route. On the left there, you can see the approach we actually took through NHS England to produce the English Targeted Lung Health Check programme. What had happened is that we were a little impatient with the speed of progress with the UK National Screening Committee, and ran a few pilots following the successful pilot UKLS randomized controlled trial. These were very encouraging and also supported the government's intention to increase the proportion of early stage cancers by 2028. So they went ahead, the NHS England, with a large pilot program called the Targeted Lung Health Check. And this, as you know, has been highly successful. And that has led now to to be adopted as the UK's lung cancer screening programme, renamed in February 2025. On the right of the slide is the usual process that's taken to approve a new screening programme. Here, the UK National Screening Committee have an independent evaluation through a health technology process sponsored by the NIHR. And they do a detailed health economics evaluation using trial data, clinical data, and costs in the NHS, and will then make a recommendation to the committee, which will then either say that screening is recommended or not. If it is recommended, then the 4 UK countries should move towards implementation of the new screening programme. That didn't actually happen until 2022, way after we started the Targeted Lung Health Check programme. These were the UK health economic evaluations that had been published when we started the re-evaluation in 2020. As you can see, there's a marked difference between the independent evaluation done by the UK National Screening Committee's evaluation group in Exeter, which is the top row of the table there, showing for just a single screen an ISA that was well above our willingness to pay threshold for screening, which is 20,000. Contrast that with the other existing publications. The first, Wines et al. Was a simple modelling study, and then Field based on the UKLS data, and Hindi based on the Manchester pilot, all of these showing more favourable cost of the ISA there. And this 2018 evaluation, which was done by the Exeter group, is widely quoted, and it is important that it's recognised that there were some major problems with this analysis. I think probably the most obvious problem was that the model that they used was poorly calibrated. Now, the model is a very sophisticated model, and it's still used in the latest evaluation. It uses a discrete event analysis whereby everything that could possibly happen to a theoretical patient in the model is analysed through Bayesian statistics to produce a posterior outcome. And the problem is that you have to ensure that the model is well calibrated to data that we actually see in real life, and this was not the case. As you can see from the table there, which shows the stage distribution that was found in the Nelson screening arm, the NLST triple screening arm, and the UKLS single screen arm, bears no relation to what the model actually produced. As you can see, it grossly overestimates, even for screen detected cancers, the proportion that are stage 4, and grossly underestimates the proportion that are stage 1. Now, that model did produce a stage shift. The stage distribution was even more unfavourable for clinically detected non-screened lung cancer. So it was very poorly calibrated, but still showed a stage shift. Added to that, there were numerous problems with the input data variables. Both the survival curves that they were using in terms of clinical outcome by stage were not correct, and many of the costings were very old costings based on treatments that were well out of date. So it was very important to make sure that we updated both the model calibration and also the input variables. So the process that the UK Lung Cancer Screening Committee follow is, first of all, to define, using an expert group, an end-to-end pathway, and to note the one that's likely to be most cost effective. Secondly, to run on to the calibration of the model, and indeed we had a group that looked to see whether the existing model was in fact the one that should be used in the ongoing analysis. And we also looked here at the survival by stage, which is very important to know what the survival by stage is for clinically detected and screen detected cancers, because they are markedly different. And then finally, we looked at the inputs and resource usage, which includes all of the diagnostic and staging tests and anything associated with that, and also the treatment cost by stage. The way it was done was to set up two task and finish groups. I chaired the pathway group and managed to get two other clinicians onto the modelling group. Initially, it was only going to be me, but I'm glad to say I had both Professor Matt Callister and Professor Sam James on that group, both of whom were our chief investigators of some key contemporary studies in the UK, the YLST and the Summit trial. And as I've just stated, we noted flaws in the previous analysis from 2018. A new natural history model was required. In fact, it's the same model as I understand it, but with marked recalibration. And then we undertook to obtain contemporary and accurate input data on stage distribution from the National Lung Cancer Audit. In the UK, we have excellent data from this audit telling us about the clinical presentation of all lung cancer, and also in UK screening programs, including these relatively modern trials that we had. We also obtained all diagnostic and therapeutic costs by both the National Lung Cancer Audit and experts in census, and also outcomes by stage and performance status, absolutely key here, from the National Lung Cancer Audit and the screening programs. We know from, for example, people that present clinically are of all performance status, and also a lot of those are performance status 3 and 4. So this markedly reduces the chance of survival, and that has to be modelled in the health economics evaluation, because it's a marked difference between screen detected and non-screen detected people. So, for example, here you have a slide that shows the survival for different stages there, which we're able to calculate from the National Lung Cancer Audit. And you can see on the left for performance status 0 to 2, the survival is markedly better than the survival that's seen for all performance status for the relevant age range there. So these figures were extrapolated to 5-year survival for the input into the model. And I think is much more fair representation of what would actually happen in the real world. We also identified this, what we thought was likely to be one of the most cost-effective pathways. This is just the beginning part. As you can see, it says that ever smokers are identified from our primary care record. We have relatively good data on this. There is a postal invitation followed by a telephone approach. Eligibility is assessed according to our multivariable risk models. If people are eligible and invited to a clinic and a CT scan, and have their scan and consent, etc., and then are fed into the program. If they're below the risk threshold, they are reassessed after a defined interval and may be re-invited if they become eligible. We have a lot of data, so I'm just going to run through now very rapidly some tables that show what sort of data we have. So we have, for example, here from the Manchester group and YLST, the proportion of people accepting an invite for eligibility, proportion accepting the invite for a low-dose CT, all the way through to screening compliance. We have data on the costs of administration and screening. So, for example, we were able to attribute a cost to the data extraction that's required from the primary care, which is 36,000 one-off cost. And then we have the cost of postal invitations, telephone risk assessments. These are all from either published data or trials such as the Yorkshire Lung Cancer Screening Trial. We have costs associated with a whole variety of activities around diagnostics and staging. And we have the costs of further CT scans, PET scans, etc., all added in terms of the proportion of people that are referred from the MDT. And then this shows how we managed the costs of diagnostics and therapy. And you can see it's split up according to the stages at diagnosis, ongoing, and at recurrence. So all of these were fed into the model. This is the table for chemo, radiotherapy, immunotherapy, etc. And these are the results that were obtained that were published in November 2022. There was an interim analysis which showed an even more favourable ISA, where the original natural history model was used. This is with the revised model, which was calibrated to the National Lung Cancer Screening Trial stage distribution data. And as you can see, lots of potential scenarios that could be cost effective here, and on the cost effectiveness frontier, the most favorable one was annual, age 55 to 75, with a baseline rate of 1.5% risk over 6 years. And as you can see, the ISA was well within the range that is accepted in the UK, well below £20,000 per QALY. And there are a number of other potential scenarios that could have been better, notably this higher risk value here, which costs less but would detect fewer lung cancers. So the recommendation went forward with from the UK National Screening Committee for annual screening 55 to 75, with those at the defined increased risk, leaving that open in case we do change the risk threshold at some stage. This shows the plot of incremental quality adjusted life years versus no screening and incremental costs versus no screening. As you can see, the two diamonds there are annual screening. There are also relatively favourable biennial screening here, arrowed, which could be used if you want to save on both pressure on capacity and also pressure on overall cost. So this is the revised table now, excluding the 2018 analysis. And as you can see, there is a remarkable similarity between the cost per QALY, whatever approach you use. Interestingly, one of the things that made me nervous during these 2 years of revising the model was that we weren't sure we were going to get any results out of it. So I also worked with Jansi Pan and colleagues to do a rather more simple model, which was criticised quite a bit by the independent evaluations, it has to be said. But they used annual Nelson criteria and achieved a lower cost, which would be expected because the Nelson approach is rather better than what was modelled with regards to the National Lung Cancer Screening Trial. So this was a recommendation in initially as a draft recommendation in June 2022 and finalised in September 2022, and this was followed up by UK government approval. So in summary, I hope that I've shown you that health economics evaluations can be very complex and rely heavily on accurate model and input data. But it's very important, if you've got a really good model, then you don't then need to run a full randomized control trial to test whether a different scenario might work. This can be used then for planning future screening programs, which is why it's so important. And important requirements are the end-to-end pathway, a model that's verified against known data for both screen detected and clinical presentation. Those data aren't always available in some countries. Survival by stage and performance status, a contemporary, as far as possible, resource usage data, which can make a huge difference. And as I've said, most evaluations don't have accurate data on non-screen detected people outside of a trial. So this can be quite a limitation. As I've said, this was a lot of work by a lot of people, some of whom are listed here. There's also a lot of supportive organisations. So thank you very much for your attention.
I think very important to see the complexity of the model and the importance of including all of those data points and outcomes. which I'm sure we'll dig into more in the panel discussion. So I'm going to welcome back everyone. So Thomas, Renata, PC Yang, and David to join our panel discussion. As a reminder, thank you very much for the questions that have come in. I will get to those and come through those sequentially. Please do keep sharing your questions in the chat, in the Q&A box, while the panel discussion gets going. So just as a starting point, I think in each of your presentations, we very clearly saw how important the sort of data, whether that be from clinical trials or pilot programs, is in building the economic case for screening. Just on the flip side of data availability, I'm sure there may well be examples of where data is limited. There might be limited availability of data or quality of data, and how that has impacted the process of building these economic evaluations. David, you look like you're raring to chip in there, so I'll start with you.
Yes, I mean we've been very lucky in terms of having both a number of screening trials, and Matt Callister was CI of the YLST, and Sam James is CI of Summit Trial. So both of them shared data on either administrative costs or stage distributions in the screening programs. That was incredibly helpful. And then our national lung cancer audit, which is real world data, is very, very useful. But you do have missing bits. And for example, in the national lung cancer audit, because of the time it takes to do 5-year survival, we hadn't really got accurate 5-year survival data. So we had to do extrapolation for that. Now, that is an uncertainty. And I can tell you that the team that did the extrapolation used possibly the worst case scenario on that. So they were always erring on the side of caution in terms of cost effectiveness, and absolutely resolutely refused to include smoking cessation in the argument, which, as we've heard, is a very important way in which you can improve things in the smoking populations. But the great thing about a model, a really well developed model, is that you can use it to model new scenarios. You don't have to do a new randomized controlled trial. If it's accurate and you can show it's accurate in one scenario, it ought to be accurate in another scenario, provided you're using the same input variables and you're using the same natural history model, which has been validated and well calibrated. So a lot of it is, you've got to be careful. You've got to make sure that an expert group have been involved, both from the modelling and statistical sections, but also the clinical sections, to have a sense check before you extrapolate your data, which is what a lot of people do anyway.
Great, thank you, David. Thomas, I wonder if I could come to you with the same question on where data might be more limited in quality or availability in building the economic case.
Yeah, so the Swedish example is actually the opposite from what David just explained, because we did not have a pilot program in Sweden that we could base our assumptions on. So we really had to, look into the literature and see what other pilot programs, or the NLST or Nelson, what were the parameters that came out of those trials and pilots. And then we involved an expert, to verify and validate all assumptions regarding the costs, regarding how the pathway will or could be structured, because there's no example from Sweden, and so you having this broad expert group with different expertise is absolutely crucial to build a reliable model. Yes.
Thank you, Thomas. Professor Yang, did you want to come in on that as well from your experience in Taiwan?
Regarding the
on the sort of availability of data, or any limitations that you encountered when you were building the economic case and cost effectiveness analyses for the program?
Yeah, actually, in the talent study, all the data are available, and even in the nationwide low city screening program, we collect all the images and also the demographic information, and also the income and the demographics of each individuals participating in the clinical trial. So all the data are available we are able to build the cost effectiveness studies. And also we are start to correct the sample from the nationwide low city screening program. So we are able to test the biomarker, whether they are helpful for us to identify the high-risk subjects.
Thank you very much. Renata, same question to you from your experience in Czech Republic.
Yeah, thank you very much for the question. I think that in the Czech Republic, we currently don't have a registry of people, so it's really hard for us to tell who is the proper target population, because we have no information about the smoking status of people in the Czech Republic. So our models are based only on estimation from public health surveys or something like that. So something like a better registry of people in the Czech Republic will definitely improve the situation with the models as well as with the whole screening process.
Thank you very much, each of you. Just coming to some questions from the Q&A from the audience now. Thomas, I think you'd indicated that you wanted to answer the question on the potential impacts of digital pathology on screening and also AI on radiology for screening as well.
Yeah, and it's true that I meant or was talking of, or alluding to AI-based pathology, because one of the key issues that we realized in Sweden is that even though our analysis shows that the program would be cost-effective, once you implement it, you still have the capacity issue. You need additional radiologists to look at all of the scans, and where should they come from? We're already struggling with our resources in Sweden, but then if you don't want to have a double reading of the scans, you could use AI to replace one of the radiologists. And we did a report last year on that and showed that, well, it could potentially work and will have major cost implications for a lung cancer screening program. So it would make it even more cost effective.
Thank you. David, did you want to feed into that question as well at all? You were nodding along there.
So certainly picking up the AI aspect of things, it's there's some low-level AI which is used in the British program routinely. So the nodule detection and measurement is used pretty much routinely now, which saves a lot of radiological time. We don't have double reading. We have gone down the route of having single read with computer-aided detection present the whole time. So that's sort of usual. And then it's sort of quite good training at the beginning, and then an external quality assurance package where we have a separate group of cases which all the radiologists that report on our program have to take a test on every year, and they're fed back their results, and any outliers are then are given extra training if they're a severe outlier. So we've gone down that route. The double reading approach, of course, is something that is used in the clinical trials, and you can't help noticing that the early stage detection rate in certainly the more modern clinical trials is higher than that in the real programs. So that does imply to me we've got some work to do with regards to radiological accuracy. But the resource implications, as you say, from double reading is huge. And, the system, the way we have is a double read for just a few of the first 50 cases. And then there is a regular audit process that goes on with the occasional double read of selected cases. So it's about quality assurance, I think, there. I agree with you. When the AI is up to standard, it could well be a second reporter, but I'm not sure we have any data yet to say that is the case, and that could therefore be fed into a cost effectiveness argument. And then of course you've got to pay for your AI, so you have to figure that whether that's cost effective as well.
Absolutely, thank you, David. PC, did you want to come in on that question around AI, particularly given its use in your setting?
Yeah, actually, we just started a prospective trial to. We also retrospectively to validate the AI algorithm, the SIBR, the algorithm developed by the MIT by Regina, and we are using that to test the talent result and also our nationwide auto-city screening result, whether the SIBR can help us to identify or stratify the risk from the first CT scan in our trial, and also to help us to stratify the high-risk subject, which maybe we need to shorten the interval, but for a low-risk one, we can extend the screening interval. So we just started that program in Taiwan now. Yes.
Thank you very much. And just kind of continuing on the AI theme, so a question from an audience member that we've been talking about AI on the screening program side and on the modelling side. Are there any other kind of applications of AI to kind of help with lung cancer screening efforts around the world that we haven't talked about so far? I mean, one that comes to mind, kind of bringing in another question, is on the incidentally detected lung cancers through not through a screening program. Perhaps, David, did you want to speak about that?
Yeah. So there's lots of stuff out there, but it is at the early stage as far as I can see, and it's rapidly advancing. But you've got things like quantification of incidental findings, for example, quantifying emphysema, coronary artery calcification, interstitial lung abnormality. That's available at the moment. It isn't actually in place yet in a screening program as far as I'm aware, but that's a possibility. That could speed the report, and it could increase the accuracy of actions for those findings. As I said, we pretty routinely use computer-aided detection and volumetry, which is relatively low artificial intelligence. Then you've got things like Sybil that looks at the whole CT and can potentially stratify things. Then you have things that look at nodules and triage nodules into worrying ones and less worrying ones that could harm the patient, ones that don't. So there's a whole host of things out there that is potential. The worry for me is first of all the cost, and secondly how it might run on a real CT and how long it might take to do that. But I'm aware that there is some really good stuff coming out there with whole CT reporting and all sorts of things that are on the horizon. So I guess it's watch this space from the point of view of because this is really about health economics. So you always need to think is how much is this going to cost? What are the hidden problems with this? What extra futile actions might it cause, which then have to be costed? All of these things need to be factored in to the cost effectiveness, I think.
Thanks, David. Renata, did you want to kind of feed into that question on cost effectiveness and AI and other technologies in what you're looking at for the Czech Republic?
Yeah, but AI is being discussed in our national screening committee by radiology experts. But it is not our main focus these days because we are like in the middle or in the second half of the pilot program. And it is not the main focus for us, but we are observing the international development with this AI in radiology, for example. Yeah.
Thank you very much. So, David, there's a specific question around you on one of the kind of core kind of components of the screening program in England, which is on mobile CT to increase access. From a cost effectiveness perspective, could you kind of explain the impact that that's having on cost effectiveness and kind of the balance between the improved access, potential challenges in terms of cost and logistics that may come with that as well?
Okay, so really called me out on that one. So there's several things here. First of all, when you do these cost effectiveness analysis, you see the publications. People will quite often highlight what the key drivers of the cost effectiveness are, and commonly the cost of the CT scan, which is the screening test, is a key driver of the the overall cost effectiveness. And when you are modeling costs, you need to keep a consistent approach, I think, to the way you model the costs. So if you get a data source which is generally producing maybe a different cost to what you see in the real world, you need to be consistent with that data source. So if you model a certain CT cost and it's quite low, then other costs, which are also quite low because you're using the same data source, should stay there. What you can't do is then say, oh, actually, the cost of this one thing is much higher, so we're going to put that into the model, and all of a sudden it becomes non-cost effective because all the other costs are also higher. unless you've actually looked at it in detail. And that is a flaw with having a model versus the real world. So it may well apply to this mobile system that we have in the UK, where a lot of the screening activity is via mobile scanners, where the cost of that intervention is higher than what we modelled in our health economics model. And the drive then, of course, is to try to reduce that cost as the programme rolls out. The main emphasis on the programme has been to ensure that it rolls out at speed, and I think it's one of the most successful programmes to do that, because we're now at nearly 35% coverage in terms of the eligible population. 35% been offered that. That's a substantial amount of offers, over 2.5 million invites already. And we've only really been going at pace since about mid-2021. Started in 2019, but it was originally quite a slow start. So yes, the actual cost of the program may be very different from what you're modelling, and the cost effectiveness may depend on these new values, and whether or not to redo the model with the new values will be whether you can be very reliable in the amount of costs. And I think it will be a good idea to look at the real costs of the program, feed those into the model, and see what the cost effectiveness is. And I imagine that will happen at some stage. At the moment, we're focused on implementation, and it wouldn't be fair, I don't think, at this stage to do that analysis, because I anticipate that costs will come down as the program gets to full rollout and we start to use fixed site scanners and other methods to try and reduce the cost.
Thanks, David. And also kind of critical, taking just outside of the pure economic discussion, the critical part of that is having kind of greater access and participation for all of the eligible population, as well as is a kind of key component in the upcoming programme in Australia too.
Yeah, absolutely.
Thomas, I wondered if you had a kind of perspective to share, kind of maybe broadening that question out to, we can do these models and they're very important, but when you kind of get into the real world data and kind of refeeding models and kind of regenerating the evaluations based on kind of emerging evidence of the latest data, and from a kind of health economics perspective, what best practices are for taking that approach?
Well, first of all, I think this is rarely done. Usually you do a cost effectiveness analysis, then you make a decision based on that, and then the decision makers are happy and content. But then doing a re-evaluation, unless there is a major scandal or anything, it's rarely done. But I think Renata also said it in her presentation that there are plans in Czechia to actually do a re-evaluation, which I think is a good idea. But then at the same time, I'm also listening to David saying that, I mean, we also need to wait a little bit. We can't just do a re-evaluation after the first year, because things are evolving, all involved units are learning. So we should do it, but maybe not 1 year after we started our actions, our screening actions. Yeah.
Thomas. There's another couple of more specific questions. I'm going to sort of select the ones that are more focused on health economics specifically. I think this is probably a question for you to start with, at least, Thomas, on some of the different types of economic analyses and models that are available. So somebody has asked a question on using value of information analyses, and particularly when utility value calculations might be quite difficult for lung cancer screening.
Yeah, that's a great question. And I think throughout the presentations today, we heard that there are different models, approaches, a Markov model, decision tree, natural history. There are many different approaches. I think at the end, we have to just realize that a model is a model, which will always contain a certain degree of uncertainty, and decision makers, of course, should be aware of the fact that there is uncertainty, and ideally do a reevaluation once we have clarity on many of the parameters that we had to estimate or simply guess in some cases. But there's a bit of a menu to choose from, and I don't think there's any consensus on what's really a right or wrong approach, but that's what we have.
Thanks. Thank you, Thomas. Yeah, and I think the importance of attuning to the specific location or kind of geographical area for the programme also is kind of critical part of that. We're sort of coming nearly towards the end of our time today. I would wonder if it is kind of nice time to ask each of you to kind of share some final thoughts. On that, the question that I'm going to select from the audience that I think is, I might spin it slightly to a kind of more positive ending or kind of less challenging ending for the webinar. But really, one of our attendees has asked around kind of addressing possible concerns that screening programs do need lots of resources to be implemented. Many health systems around the world are under challenges in terms of resources, whether that's financial, workforce, hospital capacity, etc. So kind of thinking about what we've been speaking about today, specifically around health economics as far as possible, any sort of reflections on how those concerns or questions have been overcome, the role of the health economics evaluations that each of you have or are conducting in making the economic case for screening in each of your countries, and lessons that others who maybe are at an earlier stage of thinking about designing or implementing a screening program can take. I wonder who to start with. Perhaps Professor Yang, maybe we could come to you first on that question.
Yeah, actually, if we did not do the lung cancer screening, more than 50% of the lung cancer patients actually diagnosed with stage 4 disease. And we have very high EGFR mutation in Eastern Asian population. 50% of them, they have EGFR mutation. And most of the advanced disease, they need target therapy and even immunotherapy if he or she did not have the EGFR mutation, is wild type. All these drugs are very, very expensive. And the government the National Health Insurance, they spend most of our resources in treating lung cancer, but the outcome is very poor. So they start to think about that we should reduce the stage 4 disease, increase the stage 1 disease by low-dose CT screening. So we target the lung cancer screening to start with those with family history of lung cancer. We already observed the stage shift, and we increased the stage 1 disease from 30% to 74%, and stage 4 disease decreased from 50% to 7%. So it is a remarkable achievement, and because of the stage shift. And now we already observe that the stage 4 disease, both in men and women, they start to decrease now. So based on that, the cost effectiveness study also showed that it is cost effective. It saved a lot of life and family because of stage 1 disease. They are potentially curable. So I say that the stage shift is very, very important by screening.
Thank you very much, Professor Yang. Renata, could I ask you to share some final reflections on kind of the importance and how to make that case and lessons that you can share to others?
Yeah, I think that I just want to add that in our country, the government and Ministry of Health is really supportive of prevention and screening. So we are quite lucky in this case, but we need to improve the health literacy with Czech people because the current coverage of the target population, not only with lung cancer screening program, but also with other screening programs, is insufficient. So I think that we really need to develop better strategies for working with the target groups for screening. Yeah, and it's the big goal for us for the next years, to have a better coverage of screening programs in the Czech Republic. Yeah.
Thank you very much. David, same question to you for some final thoughts.
So I think that I've already really said it in my conclusion slide. I think to do this properly, you have to have some clever people with regards to the health economics modelling. Good mathematicians, good statisticians, people who really know the ins and outs of whatever modelling they do. And then you have to have a group of clinicians that can spot any misinterpretations or flaws in the way they've applied the approach, to make sure that they fully understand what the end-to-end program looks like. And then you have to have support of the data. And if you can't get data, if you don't have your own data, you have to look, how does your data, there's a question in the chat, how does your data reflect the local country? How can you extrapolate that? How can you make a reasonable assumption that it will be similar in your country compared to the UK? I mean, we know, for example, survival, you'd have to be very careful about applying British survival to, survival in Australia or Canada or somewhere, because where the survival is obviously a lot better from clinically detected lung cancer. But then you need to, think about the age range, the performance status distribution, all of those sort of things would need to be corrected. So I think it's difficult, but it's absolutely essential. If you don't get the data right, then you put the wrong things in, you'll get the wrong answer out. So I think that's my last message. Make sure you put the correct things into the whatever model you've got to get the right answer back out again.
Absolutely. Thank you very much. And Thomas, with your kind of slightly more global perspective, including kind of building out from your work in Sweden, what would you share as some final thoughts for our audience today?
Well, I think looking back at the clinical evidence from the NLST and the Nelson trial, the magnitude of the mortality reduction is actually quite large, 20 to 30% reduction of lung cancer mortality, thanks to this amazing stage shift that we are able to achieve, as Professor Yang just mentioned. And, if we would have a new medicine that would achieve such a big mortality reduction as lung cancer screening, everybody would be like screaming and standing up and applauding at a oncology congress where the trial results are presented, simply because the magnitude is so big. So I think we should really appreciate the fact that we have a technology now that really seems to work, seems to be robust, low-dose CT screening that can make a huge impact for patients. Nevertheless, any cost effectiveness analysis should be done at the national level, because the cost structures, the cost implications differ from country to country. But overall, I think we have a huge potential here, really a huge potential to save many lives and have a positive impact for millions of people, actually.
Thank you very much, Thomas, and thank you everyone for your presentations and such an engaging discussion today. Thank you all of our participants today who've shared your questions in the chat. I fully appreciate we didn't quite have time to get to all of them. So please do keep an eye on the Lung Cancer Policy Network's website and on LinkedIn, where we will try our best to answer as many of your questions as possible through those forums. And as a reminder, if your role involves thinking about starting to design or plan for or make the policy arguments for lung cancer screening in your locations, you can access some of the implementation resources that the Lung Cancer Policy Network has available using the QR code or the links on the right-hand side of the screen. They're all freely available. And if you have any questions about how to use them, including the resources on financial planning, but many more as well, then please don't hesitate to get in touch. Thank you very much all for your time today. And thank you once again to our panelists, and not forgetting Professor Stargardt, who joined ahead of time to share his thoughts in advance, and wishing you a wonderful rest of your day. Thank you so much.